Hello everyone, this is Dr. Alnouri. I'm Laryngology Fellow at Drexel University. Today we will talk about the diagnostic value of acoustic and aerodynamic measurements in vocal fold movement disorders and their correlation with laryngeal electromyography and voice handicap index. Vocal fold movement disorders may be range from mild paresis to complete paralysis and can be temporary or permanent. Acoustic variables used most include jitter, shimmer, standard deviation of fundamental frequency, RAP, and NHR, or noise to harmonic ratio. Voice handicap index measures the influence of voice problems on the patient quality of life. Laryngeal EMG is the gold standard for evaluating laryngeal neuromuscular function objectively. The goal of this study was to determine the relation between acoustic voice measures, laryngeal EMG, and voice handicap index, and determine which acoustic voice measures have significant value in predicting severity of vocal fold motion disorders. 492 records were reviewed retrospectively. Inclusion required complete documentation of 3 parameters: acoustic voice analysis, laryngeal EMG, and voice handicap index. All patients filled out the voice handicap index questionnaire during their initial visit, which was within 30 days of the laryngeal EMG procedure and the acoustic voice analysis. Acoustic measurements were obtained by one of 2 certified speech-language pathologists using K-Pentax. The average of 5 trials of vowel A were attempted utilizing the multidimensional voice program software. The acoustic parameters were recorded as 0, +1, +2, +3, or -1, -2, -3 standard deviations from the normative reference points for males and females. The standard deviations utilized were obtained from the software from the K-Pentax machine. Average acoustic score was calculated for each subject. Average acoustic score was the mean of jitter, shimmer, RAP, noise to harmonic ratio, standard deviation of fundamental frequency using absolute values. 6 muscles laryngeal EMG was performed by one of 2 board-certified otolaryngologists with extensive experience in laryngeal EMG. The percent recruitment of the TA and PCA muscles were averaged to determine the percent function of each recurrent laryngeal nerve. The percent function of the left and right superior laryngeal nerve were the same as the percent recruitment for the left and right CT muscles. The grade of paresis was determined for each subject based on the nerve with lowest percent function. So if the nerve function fell within the range of 70 to 90%, it was considered mild. From 21 to 69%, it was considered moderate. And from 0 to 20, it was considered severe. Score of 1, 2, 3 was assigned to the subject respectively. Statistical analysis were completed using F.A.C.S and the Spearman-Rho correlation coefficients were used to analyze the relationship between laryngeal EMG, acoustic measures, and voice handicap index. Two tail tests were utilized to assess significance. So the results, 313 subjects were included in the study. The mean age was 44 years. We had 122 males and 191 females. So this is the table of the results. So as we can see, while many of the correlations are well beyond chance, none are of large or even moderate magnitude. We can see here that voice handicap index was better correlated with the average acoustic score than grade of paresis. We can see here that the highest correlation with voice handicap index occurred with the standard deviation of fundamental frequency, and the highest correlation with the grade of paresis was seen with shimmer. Voice handicap index demonstrated a weak but significant correlation with the grade of paresis. So from this study, we can conclude that acoustic measures, laryngeal EMG, and voice handicap index scores are at best weakly correlated. Further research should be conducted to confirm or refute these findings. Thank you.